Hello, everybody, and welcome to this webinar talking about Tempus Next, using AI to identify and close gaps in care for cancer patients. Thanks for joining today. If we go to the next slide, let me remind people to utilize the Q&A function to submit questions throughout the discussion. That's located at the bottom of your Zoom, and we'll leave plenty of time for questions at the end. And I'm sure people will have quite a bit to discuss because this is really such an exciting area and things are happening so quickly. If we go to the next slide. It's my pleasure to introduce Karen Hulsman, who is the Precision Oncology Lead and Genetic Counselor at TriHealth. As we'll talk about in the fireside chat portion of this program, Karen will tell us how TriHealth has utilized the NEXT program and give her impressions and thoughts. And really excited to have you aboard, Karen. Thank you so much.
Glad to be here.
And I'm Ezra Cohen. I'm the Chief Medical Officer for Oncology at Tempus AI. Once again, thank you to all the participants for joining. Go ahead to the next slide. Let me start us off with just laying the foundation for what this program is and how we envisioned it and what need it fills in medical practice. I think for most of you on the call, especially for those of you who are providers to oncology patients, you'll agree that there has been an explosion in the past decade of clinical guidelines, and especially with respect to precision oncology and targeted therapies. Just to put this into perspective, for non-small cell lung cancer, the NCCN guidelines are now 256 pages. For breast cancer, it's 291 pages. And for heart failure, this is the guidelines from the AHA and ACC, they're 178 pages. And those are just single entities within much larger diseases. So it becomes very difficult for a single provider to really keep up on all of these specifics. Go ahead to the next slide. And again, to put it into perspective and maybe more specifically, non-small cell lung cancer, looking at the past decade, there have been literally dozens of new therapies that are indicated for specific types of non-small cell lung cancer. I remember training as a fellow, this is a little while ago, and non-small cell lung cancer was essentially carboplatin and paclitaxel. It is now much more complex than that. And first, you can see that there are 28 new therapies that have been approved just since 2000 in non-small cell lung cancer, and leading, of course, to highly variable treatment journeys. The graphic on the left is how in the real world patients are being treated with these new therapies. So it's become really difficult for the average provider and even for those with an interest in non-small cell lung cancer to keep up. Go ahead to the next slide. And really this next set of slides puts this care gap analysis and program into perspective. The increasing complexity of these guidelines has accelerated physician burnout, and the gaps are only becoming more persistent and pervasive. If we look at 1,000 patients with newly diagnosed non-small cell lung cancer, you can see that the first gap is referral to biopsy. So about 6.6% of those 1,000 will actually not get a biopsy. Go ahead and to the next one. And about almost 15%, the biospecimen will never be collected. So now we're up to about 20% of patients who will never get molecular testing. Go ahead to the next. Another 1.7 where the biospecimen will not be evaluated for whatever reason. Go ahead to the next. The fourth gap, and this is one of the largest ones, about 20% will never get a biomarker test ordered. So they won't, although there's a specimen, the appropriate testing won't get done. About another 20%, unfortunately, the performance of the test will be inadequate and therefore a result will never be delivered. About 4%, for whatever reason, the report will never be issued. And go ahead to the next one. And then about 30%, and this is the largest one, about 30%, a treatment decision will not be made. And it's that last gap where we felt we could make significant impact by introducing an AI platform to help providers make that decision. But if you added all these up, from the 1,000 patients that we started, only about 350 will get the appropriate guideline indicated therapy. Go ahead to the next slide. Oh, go ahead to the next slide. We sort of said that. So to put this into perspective, does this matter? And we think, and I think many of you on the call or the webinar will agree, it can make a tremendous difference in patient outcomes. So here are 3 examples. EGFR mutated non-small cell lung cancer, for those patients with earlier stage disease who receive osimertinib, based on an FDA approval, there will be an 80% reduction in the risk of disease recurrence or death. 80%. Another example is for patients with MSI high castrate resistant prostate cancer. For those patients who receive an appropriately and approved anti-PD-1 or PD-L1, there's a 50% decline in PSA levels. And then lastly, according to, again, prospective data, for patients with FGFR2 fusions in intrahepatic cholangiocarcinoma, those patients who get appropriate therapy have a response rate of 42%. So these are really tremendous differences in patients' lives and outcomes if the appropriate therapy is matched to that molecular alteration. And if we go to the next slide, here, putting it all together, improved adherence to clinical guidelines through an AI-enabled, accurate and targeted notification system at the point of care is what Next is all about. Essentially, we can take multimodal patient data. This includes clinical, laboratory, progress notes, radiology, molecular pathology, and in the case of cardiology, echocardiograms and electrocardiograms, put them together with the evidence-based care guidelines. So these can come from multiple sources. For oncology, it can be NCCN, it can be ASCO and other bodies. We can put that together with clinical research and trials, best practices and care pathways, all into this Tempus Next platform, which is an AI-enabled patient identification without, of course, any PHI, automate the process and provide oncologists or cardiologists, as the case may be, with directed notifications that apply to that patient that they are seeing. It's an incredible tool, really just to help bridge that gap, that largest gap that we saw earlier of having the test, but then being able to connect it to that appropriate patient. Go to the next slide and let's start our fireside chat. And once again, really thanks, Karen, for joining us today. And you're, of course, a user of the Tempus Next. But first, before we get into that, can you describe your role at TriHealth and how did it intersect with what Tempus is doing?
Yeah, thanks so much. Well, first of all, I will note there is no fire here, but it was raining today in Cincinnati. Um, I'm a genetic counselor by training, actually. I've been working in oncology genetics since the year that BRCA1 was identified, which I won't say. And in my role now as precision oncology lead, I'm 20% clinical and 80% administrative. So I'm in a dyad with Dr. Andy Parchman. He's an oncologist here at TriHealth who specializes in lung cancer. And so naturally, this project is really crucial and of high interest for both of us. With regard to my clinical role, I support the medical oncology providers in getting the most genomic information for clinical decision making. And, I'm always there to help and adjust orders to maximize that. And then I support some of the medical science questions. I also monitor for the germline incidentals on tumor profiling, and I run our MTB. So that's kind of the clinical part of my job. And then administratively, I'll vet new tests and technology and elevate them to our scientific committee. I do the quality metrics on anything that's precision oncology. I run our leadership thought group we call Precision Oncology Work Group, or POW. And I'm a clinical champion for EMR integration for this and several other labs. And essentially, I do anything I can to support the many layers of genomics that we use in oncology today. And that can include maybe one patient that we're layering on different genomics, and then also like longitudinally over time. And so I'll also note that my undergraduate training is in engineering. It was genetic bioengineering at Purdue. And so I'm super nerdy, innately, and I enjoy working with data and the EMR, and I'm determined to be a savvy user of AI.
Gary, it sounds like TriHealth has you doing the job of 3 or 4 people, so so that's incredible. Um, and we know that precision medicine is pivotal at your institution and throughout the health system. What challenges do you face in implementing it, and how have you overcome those?
Well, as you know, a lot of our biomarker testing for tumor profile has many, many hundreds of data points and different genes and biomarkers. And, deciding on a treatment requires complex and nuanced decision making. So I'm lucky. I am not a medical oncologist. I don't ever pretend to be a medical oncologist. And, I really feel for you if you are an oncologist, because it's a lot of work, to make these decisions. And so, we see patients that have multiple tests and then results that change longitudinally, and we have guidelines that keep changing all the time. And I think there is sometimes some burnout and frustration juggling multiple labs and results. And so those are some of the challenges. And then in overcoming this, we want to demonstrate adoption of these new guidelines, and we want to have good quality metrics that improve over time on our adherence. And so, we want to give our clinicians more time to focus on patients, less time finding and coordinating results. And, I think automation of, some of these processes can definitely help streamline. I've seen that with Epic integration with ordering and resulting. We have integration with 7 different labs that we use in precision oncology. And the discrete genomics, gives a lot of power from tumor profiling and allow us to build these types of algorithms that can flag patients reliably. And I think because of the Epic integration, TriHealth is a really good partner for pilots like this.
Yeah, yeah. So we'll talk about Tempus Next and how you've integrated that and used it and some of the feedback that you've been getting. But what did you do before Tempus Next?
Yeah, there is a before and after, which our go live was February 7th, and we'll talk more about that. Prior to Tempus Next, as I said, we have the discrete genomic variants in Epic, and we use the genomic module. And we've already built reporting dashboards using existing tools in Epic. And we also have some clinical decision support built in for our providers. And that's based on the discrete genomic data that we get from Tempus and other labs. And I frequently, daily, run reporting workbench reports and slicer dicer for reporting. We use that to identify patients that have specific variants like KRAS G12C or ESR1 mutations. Our clinical trial team uses it for inclusion exclusion criteria. An example, for me is every day I run a report to find new incidental germline mutations, so I can follow up on those with confirmatory testing and family cascade. But despite all of that, when we try to flag patients with multiple factors, like in Tempus Next, what we're doing, there's a point where we cannot capture all of that information. And so a good example is resectable. How do we find resectable patients? There's no discrete variable for that. And, for our stage 1B through 3 non-small cell lung cancer protocol, which we'll talk about, we don't have a way to pull out those patients without some kind of language learning model. And we have a great IS team and data analytics team that's working on this right now. But right now, Tempus was able to ingest our clinical data and give us our data back in a clinically useful way to support clinical decisions, and they did it faster. So, that was a win. I will also note, when we got started, Tempus put together our baseline attrition funnel data, looking at our patients in 2022, and we're working on 2023. And, we didn't really know this, but we had a 30% care gap before the pilot was initiated. So we had already decided to do that, but then when we found that out, it just kind of added a little bit more emphasis, about why we're doing this.
Yeah, yeah. I mean, it sounds like what you're doing before Tempest Next is pretty sophisticated, and it's interesting to hear how Tempest Next has really augmented your program. By the way, that same resectability issues when we were building the algorithm was something that we really struggled with. So I'm glad to hear that way that we weren't the only ones having difficulty. So you've talked to us a little bit about your world before Tempest Next. You've talked to us about how your team is using it. What gets you excited? What's exciting about Tempest Next, and what are the things of real value?
hmm Well, I probably need to start by saying that, at the same time as go live with Tempest Next, which was the week of February 7th of this year, we also adopted a brand new workflow for our lung cancer patients that were resectable stage 1B through 3. And we adopted that workflow coincidentally on February 7th. So, things really kind of lined up that way, which was super exciting. And so, briefly, that workflow involves, we do resection on those patients and staging, and then they're scheduled by the lung navigator with the med-onc, and then tumor profiling is ordered at that initial visit, and then the results obviously applied for therapy. And so, I support getting those orders in. I'm a provider myself, so I can, help the clinicians with getting those in sometimes. And, honestly, the thing that was so excited for me was being able to use the data that we were getting from Tempus Next for our COC, our Commission on Cancer
Mm.
standards and goals, and also just the clinical goals that I have for precision oncology at TriHealth for our Cancer Institute. So, to me, like that was like I had not thought of that when we came in, but since we just did our reporting, 2 weeks ago for that, it really highlighted like, wow, this is awesome. And I think like identifying these patients without AI would be very hard. We cannot surface these fully ourselves reliably, but we've done validity checks on the reports that we're getting, and they're spot on. After a little training on the resectable thing, and so I think we're getting these notifications that are coming at point of care. Like I'm sending inbox messages to the med-onc saying, hey, maybe we want to do biomarker testing because this patient's eligible for our protocol. Are you planning to do this? And, so it's coming right in Epic, right where they're working. And, I try to be really serviceable as far as like, here's the specimen ID, the date of collection, let me know if I can help you. And, at first I thought, oh, we're going to be annoying with all these extra inboxes. But so far I've just gotten appreciation, as far as feedback from our oncologist, which is great. And then, I think another win about this is just the operational ease of implementation. Just to be clear, like there is some time invested. You have to identify a person, which is me at TriHealth, who can navigate, receive reports, send notifications to the med-oncs. I meet weekly with the next team for usually about an hour, and that's how we learn and improve every week. And you have to have alignment with the providers and willingness to measure ourselves. It was humbling to think like, oh, we had a 30% care gap, even though we think we're doing a really great
Yeah.
job. And then, I think eventually this is all going to be automated, which is the one thing additionally that I'm excited about, where, I think we'll just have an order set that's like a one click that'll streamline this ordering. And I think someday we're going to have universal germline and somatic for all of our cancer patients. We already have a lot of universal germline for specific tumor types here at TriHealth. And so, there's a lot of treatment decision making that could be simplified and reducing time, with AI supports. And I think oncologists have a very difficult role, and AI can definitely support this process going forward.
Yeah, Ken, I think you bring up a good point. We don't know um, until we really look, and there really are care gaps and patients who are appropriate for testing that aren't. So I'm glad to hear that Tempest Next has helped identify those patients. And also, the as we move more and more to um, value metrics in care of patients. It's interesting to hear that you were able to use Tempus Next to provide data in that regard as well. So really terrific feedback and exciting times. You said you got feedback from your providers. Can you share some of that? Maybe a patient story or how it's impacted your physicians in at TriHealth?
Yeah, I can. As I said, I was a little leery because I don't want to add any new inboxes to anybody's inbox. And so I was, treading carefully. And, we did have a few cases that were, flagged. And it turned out that, not every case when we got started was actually resectable. And so I think there was a little learning on my side, a little bit of, AI learning, on your side. And so, we kind of started that way, especially with the cases that were before, like we went back to November, by the way, from November when we, signed on to do this project all the way up to February 7th. We did review all those patients, and then that was retrospectively, and then February 7th going forward. And so I have like three great cases, that I can share with you if we have time. You guide me. But the first one was like right out of the gate, the week of February 7th, I got a couple of, notifications. I followed those up on February 8th with inbox messages to our providers. And like, we definitely had at least one care gap that week that was, a true care gap. And, biomarker testing got ordered the same day. And so right at the beginning, we found a patient who needed testing. It was addressed promptly. I guess we are calling that closing the care gap. And the patient ended up having PD-L1 positive findings. So, we have several lung specialists on our team that help put together the protocol. And of course, they're well versed with all those hundreds of pages in NCCN. But this provider was one from an outlying area where we see a large variety of cancer types. So, they were not one of our lung specialists. And I think this was helpful in updating, the provider and making sure we're all adhering to new guidelines. And I really feel for those oncologists who have to juggle, a variety of tumor types. So I think that was one right out of the gate. And then, one more recently was where we got a notification. It was April 23rd, and I inboxed the provider, and she replied right back. She was like, "I appreciate the reminder. I have a quote here." She said, "I'll put that on my to-do list for when the patient comes in next week." So we looked at it the next week, and sure enough, testing was ordered 6 days later. Great job, and the results showed actionable biomarker matched with targeted therapy. And so we were really excited about that. And I asked her for some feedback, knowing that this webinar was coming up. And she said, this is a quote: "Having the PD-L1 positive result is helpful for decision making, clinical trial, and also in determining therapy. The Tempus Next program is great to have in place as a double check to ensure biomarker testing is ordered." So, this was one of our lung specialists, and I know she knows this protocol backward and forward, but even she appreciated a little bit of touch on this. And then, my third one is another physician who works is a specialist in an area other than lung, and it was kind of waiting on the testing until resection was performed, kind of had it in the back of their mind. And I think the notification served as a reminder. And this was a great one because I called it triple cherry, because the results showed a KRAS G12C and PD-L1 was 95%. And so, this clinician said, "Yes, I will use this information going forward, and I'm sure the patient will benefit from immunotherapy at some time." So I've been getting really good feedback. I think when we had the couple of cases that we thought were resectable by AI but weren't, we did some training, and everybody was very nice about it. And what's great now is I get weekly alerts from the Tempus Next crew on Mondays, and many of the recent Mondays have been, "Well, we don't have any new notifications. You don't have any care gaps this week." And so I thought it was kind of boring at first, like, "Oh, what are we really doing here with this program? There's nothing going on." But then I realized, like, oh, if I'm not getting these alerts, no notifications that week, that actually means we've got 100%
Yeah.
compliance, and so that feels really good.
Yeah, it'll be really interesting to look at the before and after in terms of real numbers, and my guess is that that's your observation is real. That as it sort of feeds on itself, right? As providers get these notifications, they become more let's say wary or more attuned to the patients, and so the notifications may slow down, but then once in a while another one comes up, and so I think the system feeds itself to get better and better. So and certainly these conversations with you on a weekly basis are quite helpful. Um, so we've got quite a few participants on the Zoom. I think Many of them are work in health systems that may be good candidates for something like Next. What advice would you have for a health system that is thinking about implementing something like this? What are the first steps? What are the things to think about?
Yeah. When it was first introduced and, we were talking about it like in the fall of 2023 and late summer, you hear like Tempus Next and like, what is that? It's really hard at first to kind of figure out like, well, what is this and what will it do and how will it work? And, when we started using it, initially I was like, oh, we're just looking at EGFR. Like, well, there's so many more care gaps we should look at, and so I'm kind of a person like, let's do it all right now, which obviously is a huge mistake. You have to walk before you can run. And so, the Tempus Next model that we describe here is really just a starting point. We started with EGFR only, and then we expanded to ALK and PD-L1, and I know we're going to keep expanding. And, we'll move into other tissue types, and at some point, I'm sure we'll do automated messaging, so I won't manually be sending those. But like I said, you have to walk before you run. And I think, Next is very powerful. It's a software platform and, it helps track patients longitudinally and it gives us good notifications. The validity checks that we do on these weekly, these are actual care gaps that are being seen. And in the end, it improves patient outcomes. And so, you can take steps to implement this at your institution by asking for more information from whoever is your relationship with Tempus and see if it's a good fit. You definitely have to have somebody in my role who is willing to kind of be a go-between to take the information that comes from Tempus Next and transfer that into meaningful inboxes that aren't annoying for the oncologist, and then to be able to follow and do some review. So there was we had a weekly meeting and we still have a weekly meeting that's about an hour with the Tempus Next team, and then in addition to that, on a Monday, if I get a report with some notifications, I'll do the messaging. And that takes time too. Like there is some investment, it's not just going to press go out of the box, work for you. But I think that has enabled us both, to learn better on both sides and see how this really works and also do those really important validity checks so that now we have a lot of trust that when we're getting a notification, it's a real notification.
Yeah, absolutely. Was it hard, Karen? I'm curious to actually implement Next into your system.
I mean, yes and no. You have to have a person who's willing to do it. And,
Mhm.
as we talked about it, last fall, and we grew understanding about, what exactly is this and how it's going to work, it became apparent that someone was going to have to be that person and that someone was me. But, luckily I had enough time after clearing my plate of some other items to, be able to engage in this in the way that it deserves. And so it's hard in the way like you have to have somebody that can do this reliably. It does not have to be a genetic counselor. It could be, like our lung navigator, for example. It could be a nurse. It could be an advanced provider. Really, whoever kind of knows how to put in orders and is, reliable and able to do that. So that's the hard part as far as, making it go. But otherwise, no, I think it's been, really easy. It has not been a huge lift. So, when I look at our list of notifications, in the 12 weeks prior to go live, when we retrospectively reviewed those, we had 9 notifications. Two of those were, clear care gaps that were closed. And so, it's not a lot. It's not a heavy lift on a weekly basis, but we do a deep dive because we're doing chart review to see like, well, is it really resectable or
Yep.
not? And then, afterwards, gosh, I'm trying to remember the exact number, but I think it was 2 alerts in the 12 weeks after go live in February, leading up to, when we did our COC report. And, we had 2 notifications and they were 2 care gaps and we closed them. So, there was less time on the back end after training the AI, helping train the AI. So it ended up being less time in the end. So it's an investment up front. Like, there are some FTEs that need to be involved here. And I'm sure there'll be more investment when we try to build things out, with IS and, do this in a more automated way in Epic. But, you know, the value is, well worth the investment in my mind.
Yeah, I certainly would agree with that. And I think to your point about having somebody identified, I think more and more health systems, medical centers, be they academic or non-academic, I have that person, that precision oncology or precision medicine leader or advocate that I think would be well suited to do something like this. We live in an era of molecular diagnostics and phenotyping. Cancer is a molecular disease, so fortunately, many institutions have identified that individual already. At least that's my perception.
Yeah,
Um,
let me comment on that for a
yeah.
second, if you don't mind. So what's funny is, my position just kind of organically evolved into precision oncology and in the somatic world. And, it was like back in 2014, the oncologist asked me and another genetic counselor, Courtney Rice, to get involved with the somatic. And at that time, we were like reviewing, lab reports for possible germline, and we slowly got involved. And honestly, at first I was like, oh, there's no role for me as a genetic counselor, and now I'm like, oh, there is a huge role for me as a genetic counselor, because I'm literally working at the intersection of somatic and germline every day. And I know the genomics, so I can sometimes support and help our clinicians, but I am not a medical oncologist. I'm learning a lot about medical oncology, but I don't have the decision making skills to make those decisions. And so it's a really great partnership. And, I'm often told that my position is kind of a unicorn, like a lot of centers don't have that, but there's no reason you couldn't create one, if you didn't have one. And I often get calls, like people want to know, like, well, what's your job description and how do I, make this position, at my cancer center. So I'm always happy, to share, like a job position or any further description for sites that are interested in like creating one at their own cancer center.
That's really encouraging that people are asking you that. That I think that's great. I think you're likely to get more and more of those inquiries as time goes on. Um, so we talked about implementing Tempus Next. We talked about the before and after. Let's talk about the future for a couple of minutes. How do you see AI becoming an integral part of patient care at TriHealth? So AI in general and programs like this.
Yeah. Well, there's so much I could say here, but I know we have limited time, so I'll try to keep my comments short. I said already, like it helps us with our COC program goals, but what about other goals like COPI goals, and with CancerLink and other goals that we want to do? Like I just see this kind of blossoming more and more. And, you know, Tempus Next gave us all our data that we needed, to do our program goals. We did the validity check and the homework, but did it a lot quicker. So that was a huge win. So what other reports can we support with AI? I'm super excited about that. Not only with Next, but also with our internal AI capabilities, since we have a strong team. I think the streamlining the workflow for MedOnc and ensuring 100% compliance is awesome. We think we're doing well, and now we know we're doing well. So that feels great, and it's very encouraging for the MedOncs. And how else can we streamline going forward? And then like I said, over the last couple of weeks we didn't have many notifications, but that means we're doing a good job. So it's very satisfying and kind of looking ahead to the future. Interestingly, in January I was at the Precision Medicine World Conference, and the Tempus AI director, Martin Stump, was presenting, and I sat in on his presentation. And again, this was before we started, it was January. And he gave a beautiful talk about, identifying more complex care gaps and
Yeah.
ingesting radiomics and, even predicting outcomes, based on AI. And, all of a sudden, like the light bulb went off in my head, and I was like, oh, this is about way more than just EGFR. And so, one other kind of last comment that I want to touch on is also about health equity. I'm very big on that. And we did a study last year that showed in our cancer patient population who did and did not have tumor profiling, there was no statistical difference with respect to race and zip code of residence. So we felt really good about that. And, I think when we automate using AI and clinical decision support, the computer's applying the same algorithm to every patient objectively on clinical data, and that supports equity in testing and hopefully treatment as well. And so, my kind of personal and professional mission is to deliver executive level genomic guided care for all patients, especially those that are traditionally marginalized. And I think the next AI program and, other clinical decision support tools, really support that. So I'll kind of end on that positive thought, looking ahead with health equity.
Yeah, I love that you said that because I think that's one of the things that AI in general, including Next, really does bring to medicine is that idea of equality across all these diverse groups, and not only in the U.S. but potentially worldwide. So really glad you mentioned that. Um, Tell us a little bit. You touched upon this. How did and this is let's sorry, go to the next slide and let's go to the Q&A, because we've got a ton of questions coming in. And please keep entering your questions. The ones that we don't get to, we will after the webinar. So we're recording all the questions, and we will answer all your questions. So please keep them coming. The one question here is how did TriHealth customize Tempus Next for your needs? Was there any type of customization involved? Do you recall?
Hmm. An interesting question because you have to tease out like what is Tempus Next and what is
Mhm.
discrete variants. And so we have an HL7 connection with Tempus and other labs in precision oncology and oncology genetics. And the beauty of that is it provides discrete variants that you can run AI algos on, right? So it's hard to separate out those things. But our connection is HL7, which is much more customizable for ordering and reporting for Tempus biomarkers. And so we have a lot of little customizations that we have because it is HL7. So I think that's where most of the customizations come. But I think with Tempus Next, my name is Karen and I'm always asking for more. And I'm well known for that. And, I had a conversation, last Friday with Noah Zimmerman, who was helping me get the data I wanted. And like for our COC report, I said, I need this data sliced before and after our go live date so I could use that for COC. And, he did it and it was great. And it would have taken me forever to do it. So, that is an example, I think, of a customization. So I'm sorry I'm known for being so demanding, but it's for the patient's benefit and the clinicians in the end.
Truly, and I'm glad we could work with your institution to do all that. Um, Next question is, does Tempus Next use NGS data from any platform or just Tempus? I know the answer in general, but what about TriHealth? Are you able to use any platform?
Yes. And, I will say that we use many labs. I have 20 different labs and tests that we use in precision oncology at TriHealth. Not all are Epic integrated. It's obviously easier to collect the discrete variants that come from, for example, integrated genomic variants because, they fall into the same hole, whatever lab it is, as a somatic variant or germline variant or liquid biopsy, et cetera. And so, yes, you can ingest clinical information from other labs, but primarily if it's a discrete variant, like I know we're using LLM models and I'm not sure how deep that goes. Like if you had a PDF of a result, you could answer that for me probably on your side, like how much of that is getting ingested. But, I will say we have a strong connection with Tempus, the TIME program with clinical trials. And so because we're a very collaborative partner on that, and because it serves our patients very well in identifying clinical trials that match, Tempus is already ingesting a lot of our clinical data for that. And so it was a pretty easy, step to then move on to the Tempus Next because we already had all the legal governments, governance process figured out for that. Did that answer the question?
Yeah, so actually a lot more insight than I could provide in an answer that I could give. So that's great, Karen. The simple answer to the question is yes. We could use so Tempest Next can use any platform. It is a lot more efficient, as you described, to integrate Tempest testing, but any platform, any molecular test can be put in, and we designed it specifically that way because honestly, we felt that this was a product we wanted to provide to help patients, to help providers manage patients. And
Right.
it doesn't matter if the test comes from Tempus or another provider. It's the same molecular, alteration that we're finding. So that was
Yeah. And,
really,
I think I want to say, like, it's a good point. Like, we are already also EMR integrated and have other labs in pipeline. And, it includes lots of other labs like
yeah.
Caris and Garden and Signatera and Ambry and OneOme and Invitae and, blah, blah, blah. So, we either do or will soon have discrete variants from all of those labs. And, we want to make sure that all of that information is getting ingested for the benefit of the patient.
Exactly, exactly. So let's go to another question. Can you tell us more about the quality metrics and analytics that Tempus Next has helped you with?
Yeah. So if you know COC accreditation standards, and the guidebook on that is 120 pages long, I'm just going to say, um, each of our tumor sites for COC has to do clinical goals. So, for example, I'm a tumor site also, but my tumor site is precision oncology. But there's also like a lung report and a breast report and a GI report. So everybody has to have clinical goals and standards for COC by site. And then we also identify like program wide, what we call program goals. And those are usually like big ones, that are really important. They're 3-year goals. We tend to use like, for example, I think if memory serves, this one is a standard 7.2 and 7.3 for lung, but it's a program goal for Tri-Health Cancer and Blood Institute for 7.3, which is a quality improvement measure. So you have to demonstrate like, what are the guidelines, what was your baseline data, identify the problem, identify some interventions to improve, and then you have to show very clear metrics over a 3-year period in a very clear way, that COC wants it to earn your accreditation. And so I have other goals as well, like for me I use standard 8.1 is barriers to care for COC, and that would be another one I think you could apply Tempus Next. We use it for financial access, to gain better financial access and support for patients to remove barriers. But those are some examples that I can use that, I'm sure everybody who wants COC accreditation has to do these. And, sometimes it's like square peg in a round hole. Like you just look at the data you have and you put it in the hole that you need, which I don't agree with that. I think we should have a problem that's identified, which we did, and a solution, and you put that,
Yeah.
square peg in the square hole, and you follow the metrics over 3 years and you demonstrate actual quality improvement that addresses an actual existing problem. And I love that we're doing that and that this makes it a lot easier, because otherwise it would be me at night doing the Excels manually. And, I'm so glad I didn't have to do that fully in this case.
Yeah, yeah, wonderful. A couple more questions. I think we'll have time to get to two more. The first, real quick, is it for lung cancer only? Karen, are you guys using it for more than lung?
Right now, it's just focused in lung, but if memory serves, I think that we're going to move into breast, and I can't remember if it's GI or prostate. Like there are a couple other like on the horizons, but
Yep.
like I said, I want to do everything right now, all the time. But that would be messy and it would be time consuming. So I think we want to like perfect this process, and I think we are, and then we'll continue to expand. So I know we'll evolve into other tumor types probably before the end of the year. And I think it's kind of like, we have to be aligned, like Tempest has to be ready to do it, and we have to be ready to do it at the same time to expand. And I kind of like that we can, do it kind of based on our needs, but also based on, our abilities, like, the FTE time to put in to make this work. Because I know when we start in a whole nother tumor type, there might be some other
Yeah.
factors like the resectable that we might have to do some more training on.
Yeah, yeah. So you're quite right. Breast and prostate are going to roll out very soon. There is also cardiology. So Next has a couple of cardiology care gaps that it's addressing. So it's not just oncology. We've got applications.
Yeah, I will say we are also a part of the cardiology
I thought you
program.
were. Yeah.
Yeah,
Okay.
we're not doing the Tempest Next part, but we're doing the outcome prediction, I think. I'm not very much involved in that, but I know it's involving EKG and,
Yeah.
predicting outcomes.
Yeah. Yeah. And then maybe one more question, real quick, Karen. How long did it take to train the AI, and is the training specific to the institution?
Whew, that's a long one. Okay.
Okay, but you've got 30 seconds.
Right, 30 seconds. It did not take long to train the AI. I mean, we had like 12 weeks before go live, and that's where we had 9 notifications. And of those notifications, maybe 7 of those, maybe 6 or 7, were, really not resectable, but they were flagged anyway. And so when we did a deep dive on chart review, that's how we found it. So, less than 12 weeks, we've obviously fixed it now because we're not getting inappropriate alerts, for non-resectable patients. Um, and but it was like, how long did it take and how did we do it? Was that the second part?
And it was really, is it specific to the institution?
Ah, right. Okay. That's an interesting question because when we went through this, what has come to my mind is like, we need a discrete variant for resectable or not, and how could I have our IS team build that in? Because then the lug navigator could just check, and say like, yes, this is resectable or not, and then we wouldn't have to use LLM, AI training. So it was easy to do. It didn't take that long, and as far as institution specific. I think if you already have a discrete variant of
Yeah.
resectability, then you're way ahead of the game. But it kind of surfaced that to my mind, like, why don't we do that? And how can I get that done? So, maybe we'll have it next year.
Yeah, yeah. So I'm guessing the time is probably based on the number of cases as well. So, well, Karen, this has been wonderful. We've talked a lot about this program and AI in general. I want to remind people that a recording of this session will be sent to all attendees and registrants. And let me just close with a couple of thoughts that really Next can be used to operationalize other AI tools that bring value to clinical practice, and it can be integrated with predictive and diagnostic algorithms as well as imaging. You mentioned that, Karen, to help with diagnoses and to help with implementation of the best possible care for patients. Many people really wonder about what is going to come with AI. I think the field is it's exploding. The possibilities are almost endless. And really, the end game is to help providers make better management decisions, help close those care gaps, and at the end of the day, provide the best care possible for patients. And happy that we can do that, and really ecstatic that we can be a part of it. Karen, thank you again. Your insight was invaluable, tremendous. I certainly learned a lot. I hope our participants did. And we'll be sure to have more of these in the future. Thanks so
Yeah,
much.
sounds great. And I will mention, I'm going to be up at ASCO. I know that Tempus is having a reception, and I'm happy to answer people's questions then. I'm also on LinkedIn if you want to send me a question, and I'm willing to hang out for a couple minutes here if you want to hang out for any additional questions.